And specifically, informatics nurses play an important role in leveraging health information technology to improve patient safety, quality, and efficiency of care delivery. I think all of us know we don't have enough evidence yet to know truly how that happens and what makes it happen. And I'm thrilled to see Rosemary now involved with the National Quality Forum and other leaders really leading us forward in that way. So informatics nurses are also integral to achieving a vision that's going to require a nationwide effort to adopt and implement EHR systems in a meaningful way. It was mentioned that when you look at the meaningful use criteria, it seems to be very physician-centric, but it's definitely not going to happen without the data that gets documented by nurses and the systems implemented in a way that leverages that knowledge. The future of nursing relies on this transformation, as well as on the important role of nurses in achieving this digital revolution. So truly, we need to be supported by a healthcare environment that enables our knowledge-based work. And we need that support in our roles as leaders in the effective design and use of EHR systems, as integrators of information, as full partners in decision-making, as care coordinators across disciplines, as experts to improve quality, safety, efficiency, and reduce health disparities, as advocates for engaging patients and families, as contributors to standardize the EHR infrastructure, as researchers on safe patient care, and as educators for preparing the workforce. In the past year at HIMSS, we did a survey on what is the impact of the informatics nurse, and we wanted to know what was the most important value that they bring to the table, what are the roles that they're working on. So I brought just a few slides from that data, but I reference it on the last slide on the ANI website as well as on the HIMSS website. We surveyed the leaders, so it was the chief information officers, the CEOs, the chief nurse informatics officers like Vicki Bradley, and asked them what the roles are of the nurses in their organizations. We had 432 respondents, and you can see the number one item was related to user education, a critical role for these nurses. The second one, though, was systems implementation, and I think that's truly what we're here to talk with you about today, and I think you've heard definitely the importance of nurses at the table for that. User support, workflow analysis, these are some of the key roles that we play and I think impact the systems projects. Another data point is the value of informatics nurses with regard to clinical systems. So this is on a scale of 1 to 7. The highest value was perceived to be in implementation. So on a scale of 1 to 7, 6.29 felt that that was the most important part of what we do. So again, relates very much to what we're talking about here today. Analysis, design, optimization seem to be a newer term, and really trying to make sure we get that value out of the systems, and then selection, another key value point. Then the last slide, in success in achieving organizational objectives, again on a scale of 1 to 7, making sure IT does no harm. I think that was really important to the chief information officers because obviously they feel quite responsible when that happens, but we all share in that. And that's really an important role for informatics nurses to play. Making sure that the medications are correct, clinical reporting is improved, quality is improved, preventing never events. So some of the critical success factors related to informatics nursing. So finally, I just want to restate that it's essential, as every one of us has said, to involve nurses in all aspects of the EHR implementation for success, and to recognize that nurses are leaders and partners, and maybe working with NEHC to help to get the efforts supported to improve patient safety and the efficiency of care delivery, and we're more than willing to work with you towards that goal. And thank you again for the opportunity. I do recall, John, a year ago when we were seeking to make sure that this group knew about nurses, and you invited us to a meeting, and we really appreciate that invitation, and here we are a year later, and very happy to be working with you on this. Thank you.
Well, we're very pleased as well. It's just amazing how a good year goes by that quickly. This is just a spectacular, and thanks to all of you. Linda Fischetti is going to moderate this panel. And again, for those who are online, please feel free to submit your questions, and we'll try to get to them. We'll begin with members of our board, starting with Steve Finley.
Hi. Curtis, at Kaiser, what's the relationship between the docs and the nurses with respect to entering things on the EHR?
Sure. There are areas in which they do their own documentation. So the physicians have the responsibility and obligation to enter their own orders that they would previously write down and that would be transcribed by either a nurse or a clerk into the system. So they have ownership to do their own order entry as well as their documentation. And then nursing has their obligation to enter any vital signs that they collect. Right now we're working on biomedical device integration. I'll be helping our enterprise do that so that some of this manual entry and what goes to that expense of collecting things and then entering it later, we have some automaticity. But nursing will enter its own vital signs and information collection and documentation against a patient's progress to care.
What about correction of mistakes?
Correction, if the provider that enters that catches that, they will correct it themselves. An example of a correction of mistake may be a physician ordering a medication, and what happens is typically that goes through pharmacy where it's verified by a pharmacist, and then it's released into the system where the nurse can then administer the medication with the aid of barcode medication administration. So one example of correcting or catching error may be the pharmacist sees it and comes back to the physician, did you really want that? Or correlating these lab values, that doesn't work. Or it could pass through there, and then the nurse could catch it when she goes to administer the medication, and using her professional judgment that this is not the right medication to give, or the patient's vital signs or other parameters make it unsafe. Yes.
Laura Adams, and then Michael Lardier.
Thank you very much for your time this morning. This was really informative. Rosemary, I think that in looking at clinical documentation, one of the places where I think we've digitized the goat path the worst is in continuing to separate the disciplines documentation. Can you comment a little bit on what you see as the evolution? Are we making any progress in understanding integrated clinical documentation and having that appear in our electronic medical records?
I think we've made tremendous progress in terms of being able to pull all disciplines into representing their domains within the electronic health record. The structured terminology is one area that gives us the capability to have a single problem list, if you will, as a concrete example, whereby we could have the various domains and the various disciplines have a single problem, and I use that term interchangeably with all due respect for physicians because it would be a diagnosis. From a nursing perspective, it could be a nursing diagnosis, and I do know of sites across the country that are representing that with the appropriate terminology, so you can have the problem code and all of the attributes around it, and you can also track whose problem, who may be the owner of it, if it's respiratory or PT, and then you can track it, but everybody can look at it in a single list. Concrete example, just a year and a half ago, before I started a doctoral program, I worked in the telemetry unit. So we had a single problem list, and I would have my nursing-related problems, fall risk, patient education, and the pulmonologist would have their medical diagnosis, and they'd be looking off of the same list. Now, the advantages with terminology and how you can structure that is they can see what they need to see from that list. And to be honest, they didn't want to see all the detail that I have related to the problem, but the pulmonologist did not discharge the patient because medically the patient looked okay, but then when he looked at fall risk, patients confused, dietary intake's not that great from all the other disciplines, it was a flag that maybe the patient shouldn't be discharged. So that requires the appropriate terminology and the use of dictionaries underneath, so you have this information at the right atomic level within the EHR. And I think from a quality perspective, we need to make sure we have those components as the right atomic level, so we can capture as a byproduct of care delivery and then actually look at the impact. A lot of the challenges, I guess, at this point are making those systems mass deployable across the nation, not just in pockets of excellence. And I think Curtis spoke to some of the people challenges. You know, there's workflow and process around it. But certainly a lot has been done that could be taken advantage of to move us further. I hope that answered your question.
Thank you. Michael?
Yes, thank you very much. Here's my question is around, I mean, it makes perfect sense to me to have nurses involved in the implementation and as part of the team. And in health centers across the country, they do take a leadership role because it's a team approach. So what are the struggles that you have with other areas having nurses involved? Because it seems that you're making the point they should be, and so maybe it's not happening. So I just want to get a better understanding of what some of those struggles are.
I can start on that. I think it is interesting, and as
Joyce, we only have an hour. It's surprising, I guess, but it has been an awakening. For example, an informatics nurse. Well, you know, what is an informatics nurse? And we made sure that Linda described what that was before we started talking, because our specialty is very new. We didn't have a scope and standards of practice until the late 90s, I guess it was. So that's one piece. I think the other is that there haven't been formal educational programs for nursing informatics until, you know, the last maybe 2 decades, and Linda's an example of someone that went through a program like that. But most of our education is grassroots and learning on the job, and so there isn't necessarily a recognition even in your own organization of, oh, that's the informatics nurse expert. It's more, you know, we need to get the system in and we need to get the users to buy in, so we're going to grab everybody that we can to help with this. So now we're moving beyond that some, but there's still a lot of education required. The other thing that we're doing is we have a grassroots effort called Tiger, Technology Informatics Guiding Education Reform, and that is focused on preparing our nursing workforce to be able to use an EHR. And I think that's another way, even educating our own selves as to what we need to know, and then educating everybody else about our role and how we can help.